everybody. Welcome to this webinar on cancer on the heart, the second part. In the previous webinar, we had discussed about the chemotherapy and the radiation effects on the heart. In this webinar, we will be discussing about the cardiovascular screening, risk assessment and surveillance before cancer treatment, surveillance and therapy during cancer treatment, and cardiovascular monitoring and management after cancer therapy. A pre-cancer cardiovascular risk stratification is advised in all patients diagnosed with cancer and awaiting chemotherapy or radiotherapy. This is to evaluate and manage short and long-term cardiac effects of different cancer managements. A baseline cardiovascular disease assessment should be done to enable further decision-making strategies. The initial approach to cardiovascular risk stratification is a proper history taking, physical examination, electrocardiography, and echocardiography. This is to identify a high-risk patient. Who is the high-risk patient? A patient with unfavorable lifestyle choices such as smoking, overweight, reduced physical activity, patients with pre-existing comorbidities such as hypertension, diabetes, angina or heart failure, patients with previous history of bypass, PCI, stroke, or other thromboembolic events, patients with poorly controlled hypertension, severe arrhythmias, or LV ejection fraction less than 50%. All these patients are considered as high risk for cardiovascular disease. According to the American Society of Clinical Oncology, a patient is deemed as high risk if he or she has received high-dose anthracyclines, that is, a cumulative doxorubicin dose more than 250 mg per square meter, or cumulative epidobicin dose more than 600. A patient who has received high-dose radiotherapy, that is more than 30 guidance, with heart in the center of the treatment field. Patient who has received low-dose anthracyclines in combination with low-dose radiotherapy or low-dose anthracycline followed by Herceptin. Low-dose anthracycline or trastuzumab alone in the presence of any of the following risk factors, such as presence of more than 2 cardiovascular risk factors, age more than 60 years, compromised cardiac function witnessed by an ejection fraction between 50 to 55%, history of myocardial infarction, presence of more than moderate valvular heart disease. Cardiotoxicity risk score has been suggested, which includes 2 parameters, medication-related and patient-related. High risk, that is a risk score of 4, is assigned to anthracycline, cyclophosphamide, ifosfamide, Herceptin. Intermediate, that is a risk score of 2 to docetaxel, sunitinib, sorafenib, and pertuzumab. Low risk, that is risk score of 1 to bevacizumab, dasatinib, imatinib, and lapatinib. A raised risk, that is risk score of 0 for etoposide, thalidomide, and rituximab. Coming to patient-related risk score, cardiomyopathy, CAD, hypertension, diabetes, prior or concurrent anthracyclines, prior or concurrent radiation therapy, female gender, age less than 15 or more than 65 years, each has been assigned 1 point. Cardiotoxicity risk score is considered to be a combination of both the drug-related risk plus the patient risk. More than 6 indicates a very high risk, 5 to 6 high risk, 3 to 4 intermediate risk, and 1 to 2 that is low risk, and 0 very low risk for cardiovascular disease at a later stage. Some recommendations have been given for initiation of preventive therapy to avoid cardiotoxicity secondary to chemotherapy. In very high-risk patients, it is suggested to initiate ACE inhibitors or ARBs, carvedilol, statins, and up-titrate. In such patients, chemotherapy should start after 1 week. In case of high risk, initiate the same and up-titrate along with the chemotherapy. In intermediate risk patients, discuss the risks and benefits of the treatment and proceed. In case of low risk and very low risk, no treatment or preventive strategies are advised, only monitoring is required. Coming to prevention of anthracycline cardiotoxicity, this can be by limiting the dose to less than 550 milligrams. In case of additional paclitaxel, the dose should not exceed more than 360 milligrams. Dosing schedules should be modified, and different forms of anthracyclines, that are those which have less cardiotoxicity, such as the liposomal preparations, can be used. Use of protective agents such as dextrazoxazine has been suggested. A word about the cardioprotective agent, that is the dextrazoxazine or the cardioxin. This is an iron chelator which can be administered oral. It prevents the free radical formation. It is tested, proved and valued as a protective agent to reduce the cardiotoxicity of doxorubicin. The recommended dose is 10:1, wherein doxorubicin should be given within 30 minutes of giving dextrazoxazine. However, there is some controversy that administration of this might reduce the response to chemotherapy. At present, the recommendations do not recommend for its use as initial therapy. However, it is suggested to be used in patients, especially breast patients who have received a doxorubicin dose more than 300, and should be considered in other malignancies who have also received more than 300 milligrams of doxorubicin. Coming to new prevention strategies for anthracycline cardiotoxicity, there is some role suggested for ACE inhibitors and ARBs, and this is supposed to be due to the effect of the ACE inhibitors in reducing the LV remodeling and limiting oxidative stress. Carvedilol, also because of its antioxidant and anti-apoptic properties, has been suggested to be protective in reducing the cardiotoxicity secondary to anthracyclines. Animal research has proved that it prevents the toxicity, and its prophylactic use in case of humans has also been done. In a trial, that is the Overcome trial, it was seen that the combination of enalapril plus carvedilol given as a preventive aspect before starting treatment was beneficial in reducing the LV dysfunction. However, this was seen especially in case of acute leukemia. So the ISMO guidelines suggest ACE inhibitors as first-line therapy, carvedilol, nebivolol and statin should also be considered if the patient is at high risk for developing LV dysfunction. Prophylactic heart failure with ACE inhibitors has been shown to be beneficial, especially in troponin-positive patients. This graph shows orange and blue boxes, where the orange boxes indicate patients with persistent troponin elevations, and the purple boxes are troponin-positive patients, those who have returned to normal baseline with treatment with ACE inhibitor and leptin. Prophylactic anticoagulation is also recommended for DVT in these patients, as the incidence of DVT is very high in cancer patients. Prophylactic anticoagulation for DVT is recommended for cancer patients undergoing major surgery, especially abdominal or pelvic surgery, wherein low molecular weight or unfractionated heparin is given for at least 30 days. For hospitalized patients confined to bed with acute medical condition, for high-risk ambulatory patients wherein either low molecular weight, aspirin, or warfarin at an INR around 1.5 can be given. Especially, this is recommended in myeloma patients receiving thalidomide plus dexamethasone or chemotherapy. Coming to cardiovascular surveillance and therapy during cancer management. How do we monitor? Which patient are we supposed to monitor when they are undergoing cancer treatment? This depends on the baseline cardiovascular risk profile, the specific cancer treatment that the patient is receiving, and the presence or absence of cardiac symptoms and events. How do we monitor this patient? LV ejection fraction either by 2D echo or by myocardial strain echo is the method to monitor these patients during cancer treatment. Studies have shown that a fall in LV ejection fraction of more than 10% is a marker of cardiotoxicity. The use of ECGs and troponins is optional and may add on to the evidence given by the LV ejection fraction. Which is the best method to monitor the LV ejection? This is echo, nuclear imaging, or magnetic resonance imaging. In the past, the use of RNA, that is a multiple updated gated acquisition scan, that is the MUGS scan, has been well established and validated for detection of LV ejection fraction in patients undergoing chemotherapy. The MUGS scan has shown a fall in the ejection fraction before the onset of clinical heart failure. But at present, MUGS scan has been completely replaced by the echocardiography. The role of scintigraphy, though it is sensitive for detection of cardiotoxicity, there are trials. No trial has given any evidence regarding its use. Nuclear imaging, though it has the advantage that it has limited inter-observer variability, the disadvantage is exposing the patients to further radiation, and there is limited information regarding the cardiac structure. Cardiac MRI, though it is useful, accurate, reliable, however, because of its high cost and lack of availability, it is not routinely used. Hence, it is the 2D echocardiography and myocardial strain, that is a two-dimensional spectral tracking echocardiography, which should be used for LV ejection fraction in monitoring these patients on chemotherapy. Echo is widely available, reproducible, and non-invasive. It permits the safe and serial assessment of cardiac function, though there is an intra and inter-observer variability of around 10%. It is less sensitive for detection of early stages of myocardial injury. In this condition, it is the role of the spectral track echo. It has been shown that global longitudinal strain by spectral track echocardiography is useful as an early marker of LV dysfunction. A reduction of 10 to 15% in the global longitudinal strain is the most useful parameter for prediction of cardiotoxicity. Hence, the monitoring recommendations based on CRS score indicate in patients of score more than 6, it is advisable to undergo a transthoracic echo with strain with each cycle at the end of therapy, 3 to 6 months later, and at 1 year. Optional is the use of ECG and troponins during the therapy. In CRS score of 5 to 6, that is the high risk, transthoracic echo with strain is advised every 3 cycles at the end of therapy, 3 to 6 months, and at 1 year. Use of ECG and troponins is again optional during chemotherapy. In intermediate risk, transthoracic echo with strain at the mid of the therapy, end of the therapy, and 3 to 6 months is advised. At midterm, an optional of ECG and troponin can be taken. In low risk, the option of transthoracic echo with strain is optional. Use of ECG and troponin is also optional, and that too at the end of therapy. In very low risk cases, there is no recommendations for any cardiovascular monitoring. Certain algorithms have been suggested for anthracyclines for cardiotoxicity, that is, a baseline hemodynamic assessment, that is echo assessment, then assessment at a dose of 200 mg, reassessment after each additional 50 to 100. Thereafter, reassessment is recommended at 6 to 12 months and as early as 3 months those who are high risk for cardiotoxicity, such as high dose doxorubicin of more than 400. If the ejection fraction is less than 30%, not to give anthracyclines. If it is between 30 to 50%, give anthracyclines. with serial monitoring of the ejection fraction. If more than 50%, repeat the evaluation at 250 to 300 micrograms and again echo assessment at 450. If there is a decrease in the ejection fraction of around 10%, that is, a drop of LV ejection fraction to less than 50% in patients who had a baseline of more than 50, we should stop anthracycline. And LV ejection fraction less than 30% in patients with baseline of 30 to 50% of EF, stop anthracycline. Similarly, an algorithm has been suggested for patients who are on Herceptin therapy. At ejection fraction more than 50%, we can safely continue the drug. Ejection fraction of 50%. If it is between 45 to 49% and there is less than 10% decrease from the baseline, we can continue treatment. If there is a decrease of more than 10% from the baseline, withhold treatment and then reassess and start treatment only after the ejection fraction improves to more than 50. In patients with ejection fraction less than 45, withhold the treatment and repeat the ejection fraction at 3 weeks. If the ejection fraction improves, resume the treatment or else stop and discontinue the treatment. The role of serum markers is controversial. We do not have any evidence regarding the diagnostic or prognostic role of brain natriuretic peptide, especially in predicting chemotherapy-induced cardiotoxicity. However, troponin I or T is useful in detecting acute cardiotoxicity. This can raise during treatment with both anthracycline-based protocols or with trastuzumab. However, only early and persistent elevation carries a prognostic indication of late cardiomyopathy. Coming to management of cardiotoxicity during therapy. The guidelines for management of any cardiovascular disease in cancer patients is the same as in non-cancer patients with a minor differences. Coming to management of myocardial dysfunction and heart failure, it's recommended to follow the ACC-AHA heart failure guidelines. The first line therapy is the ACE inhibitors. ARB should be given only for patients with contraindications to ACE. There is no evidence regarding the use of aldosterone receptor antagonist, that is spironolactone. However, one may consider its use in patients in NIH functional class more than 1, ejection fraction less than 35%. Beta blockers are the second main class of drugs. Hemodynamic support might be required if the medical therapy fails, such as in acute life-saving conditions, that is acute myopericarditis due to cyclophosphamide. Chronic LVHS devices may be considered as a bridge to transplant or destination therapy. This graph shows the improvement in the LV ejection fraction on initiation of enalapril early after detection of LV dysfunction. Initiation of enalapril and uptitering it along with carvedilol in patients with LV ejection fraction less than 45%, when they were followed up over a period of 3 years, restored the ejection fraction to more than 50% in nearly 42% of the patients. However, in 13% there was only a partial improvement from 10 to less than 50%. It was seen that the clinical outcome was poor in those who had no response, that is 45% of the patient, and even in those who had a partial response. What is important is the timing of initiation of heart failure therapy. That is, earlier the detection and earlier the treatment, earlier the initiation of heart failure and chemotherapy-based cardiotoxicity, the better are the results. Coming to management of myocardial ischemia, this is common with the pyridine analogs, that is the 5-fluorouracil and Lenca alkalides. So close clinical monitoring with regular ECGs. Chemotherapy should be withheld if ischemia develops. Do not start the drug until and unless there is no other alternative. Most patients will respond to conservative anti-angina therapy and supportive care. The role of prophylactic calcium channel blockers and nitrates is not clear but can be used in this subset. Management of arrhythmias and ECG and electrolyte monitoring are required at baseline, 7 to 15 days after initiation or change in the doses, monthly during the first 3 months and then periodically. The US FDA recommends temporary interruption of treatment if the QTC is more than 500 or the prolongation is more than 60 milliseconds above the baseline. Correct the electrolyte abnormalities and other risk factors, and treatment can be resumed at a reduced dose once the QTC normalizes. Torsades pointis is unusual but a serious complication and might require administration of Maxell and overdriving pacing or isoprene. Treatment of atrial fibrillation and flutter includes the rhythm management and thromboembolic prophylaxis. Hypertension requires an early and aggressive treatment. Conventional drugs can be used. However, non-dihydropyridine calcium channels should be avoided due to drug interaction. If the blood pressure is not controlled despite the treatment, dose reduction or discontinuation of the VEGF inhibitors is advised. Acute venous thromboembolism is to be treated either with low molecular weight heparin, unfractionated or fondaparinux, of which low molecular weight heparin is preferred due to its ease of administration. Thrombolytic therapy is reserved for use in massive PE or massive iliofemoral DVT where the limb is at jeopardy. After the acute treatment for 14 days, long-term treatment should be continued with low molecular weight heparin at 75 to 80% of the original dose, that is, around 150 units per kg once a day for 6 months. Low molecular weight heparin has proved to be safer and more effective than treatment with the vitamin K analogs because the latter are associated with an increased risk of bleeding. In case a VKI is used, the INR is should to be maintained between 2 to 3. At present, there are no recommendations for the use of novel oral anticoagulations in thromboembolic episodes in cancer patients. IVC filter is reserved for patients with recurrent PE despite the anticoagulation treatment or with a contraindication to anticoagulation. Coming to treatment of acute pericarditis or effusions, usually they resolve on their own or with the use of NSAIDs or colchicine. Pericardiocensis may be required for large effusions. Chronic effusions usually resolve spontaneously or may require a pericardiocensis, an extended catheter drainage, or a pericardial window for recurrences. Malignant PE secondary to cancer itself might require administration of an intrapericardial sclerosant. Peripheral arterial disease and stroke, antiplatelets are to be continued for symptomatic PAD, and some patients might require revascularization depending upon the individual condition. Which of these patients require a long-term surveillance? This depends upon the overall survival and prognosis of the patient, the cancer therapy which the patient has received, the patient's cardiovascular risk profile, and whether they suffered adverse cardiac effects during the therapy. In fact, a long-term surveillance is required for those patients who had ongoing cardiovascular disease processes or are at risk of late cardiotoxicity. Suppose in the case of cyclophosphamide, here acute cardiotoxicity is seen, and so ongoing follow-up is not necessary once recovery has occurred. In case of trastuzumab or Herceptin, cardiotoxicity is not reported after completion of therapy. Hence, there is no need to continue cardiac monitoring after completion of therapy, which is typically for 12 months. Then who requires the surveillance? Breast cancer patients, lymphoma patients, those who have received anthracycline and mediastinal radiation therapy, women who have received chemotherapy or radiation therapy, who are pregnant or planning for pregnancy. It is recommended that those who have received a anthracycline dose of more than 300 or a radiation dose to the heart of more than 30 guidance or any form of chest radiation plus anthracycline or hydrocyclophosphamide should undergo a cardiac evaluation because pregnancy is known to unmask a subclinical cardiomyopathy. These patients are prone for a premature atherosclerosis and CA. So how do we evaluate these patients? In such patients, TMT might be inconclusive, hence an invasive procedure such as either a coronary angiogram or a CT coronary angiogram would be required. In addition, a physiological assessment either by PET scan or FFR or by stress testing may also be required. Cancer patients are prone for access site complications during invasive procedures for CAD. This could be the effect of the cancer or its therapy on the hemopoietic system due to the presence of hypercoagulable state or interactions between the cancer and the cardiac drugs. To decrease the occurrence of these, the use of ultrasound guidance, micropuncture needles, and fluoroscopic guidance for access should be considered. It is recommended that in patients who are on hemodialysis, abnormal Allen's test, or undergone bilateral mastectomy or multiple previous radial punctures, one should opt for a femoral access rather than a radial access. Coming to ACS in the patients with cancer, it was seen that cancer is one of the strongest independent predictors of in-hospital death and 1-year mortality for patients with ACS, especially ST elevation MI. The mortality was threefold high when PCI was done for acute MI if the malignancy was diagnosed within 6 months. These patients had higher rate of all-cause mortality, longer hospital stays, and this resulted in higher hospital costs. They were more prone to develop acute kidney injury and required more blood transfusions. Guidelines for treatment and revascularization remain the same as in non-cancer patients, but unfortunately they are underutilized in this subset. Aortic stenosis is commonly seen in cancer patients, and a study by Yusuf et al. Showed that patients who underwent AVR had a longer survival rate than patients who had not undergone AVR. Of course, the treatment option is decided based on the survival and prognosis of the underlying cancer. Takotsubo cardiomyopathy or stress-induced cardiomyopathy is common in cancer with a prevalence of 10 to 20%, with a 5-year recurrence rate of 5 to 22%, the second episode occurring 3 to 10 years after the first one. Presence of this cardiomyopathy is a detrimental event in the overall prognosis. The survival is reduced to 30 months rather than 60 months in a patient without cancer and Takotsubo cardiomyopathy. Cancer patients face certain unique issues. One is the presence of comorbid diseases such as thrombocytopenia, difficult vascular access, which we have already discussed, and coagulopathy. Unfortunately, we do not have proper data for intervention in this patient population. However, when a combined medical and interventional approach is required, it should be discussed and performed to balance the risk-benefit profile in this patient, and the procedure timing in relation to the oncological treatment goal should be decided. A unique thing in this patient is intervention for ACS, especially in a patient with thrombocytopenia. I mentioned regarding the intervention for ACS in patients with cancers, especially with thrombocytopenia. A radial access is preferred. Prophylactic platelet transfusion is not recommended routinely. This should take up a fellow oncology or hematological recommendation. Prophylactic platelet transfusion is recommended only when the platelet counts are less than 20,000 in the setting of fever, leukocytosis, rapid fall, or presence of solid tumors. Platelet transfusion is required in case of bleeding complication pre, during, or after the procedure. Coming to heparin dose, When the platelets are less than 50,000, the heparin dose should be 30 to 50 units per kg. Coming to antiplatelets, if the platelet count is more than 10,000, aspirin can be safely used. When between 30,000 to 50,000, dual antiplatelets only with aspirin and clopidogrel is recommended. The use of prasugrel, ticagrelor, and GP2B3A inhibitors is not recommended in patients with platelet counts less than 50,000. Duration of DAPT. If the platelet counts are less than 50,000, the duration is few weeks following only a plain angioplasty, 4 weeks following implantation of a bare metal, and 6 months after implantation of drug-eluting stent, provided optimal stent expansion is confirmed by OCT or any other method. There is no minimum platelet count to perform a diagnostic coronary angiogram. So this is an algorithm showing the management of ACS in patients of cancer with thrombocytopenia. If the platelet count is less than 1 lakh, assess the TIMI risk score. Less than 3, go for medical management. If high it is more than 3, go for early invasive therapy in the cardiac cath. If it is seen to be stress-induced cardiomyopathy, resume the cancer therapy in 2 to 4 weeks. Suppose it is an obstructive cardiovascular disease and the platelet count is more than 10,000, you can go either for an implantation of the stent or a CABG if the platelet count is more than 50. If the platelet count is not more than 10,000, is more than 10,000 but less than 30, you should go only for medical management. More than 30,000, either BMS or DES, and institute the dual antiplatelet therapy. Coming to pericarditis in patients with cancer and thrombocytopenia, it's a relative contraindications. However, at present, use of micropuncture technique, lateral approach, combined echo and fluoroscopic guidance has increased the safety of pericardiocentesis. Platelet transfusion does not modify the overall risk of the procedure due to platelet refractoriness. Radiation-induced heart disease is also associated with many challenges in these patients because of the need for multiple procedures. Surgical interventions such as CABG might be difficult as the internal mammary artery is damaged by radiation and may not be a prime bypass scar. Aortic calcification poses a challenge for aortic coronary bypass, that is the saphenous, and both the saphenous and the arterial bypass. Mediastinal fibrosis may differ or make difficulties in open CABG, and hence we should prefer PCI, which is also associated with increased risk due to the presence of severe lesions and calcified lesions. Coming to pericardectomy for constrictive pericarditis, it is advised to do a cath study to exclude underlying restrictive cardiomyopathy, since radiation therapy can also affect the myocardial and endocardial fibrosis. It has been seen in many cases that post-cardiac pericardectomy for constrictive pericarditis, there was no symptomatic relief because the underlying restrictive cardiomyopathy came into picture. Coming to treatment of arrhythmias, especially for VT in these patients, one should be cautious as there is a risk of heart blocks due to degeneration of the conduction system. So the take-home message is, though there is improved outcome following advances in the cancer therapy, this is offset by the impact of cardiovascular side effects. There is a need to develop cardio-oncology units just staffed by dedicated specialists for early recognition and treatment of cardiotoxicity, for pre-cancer therapy, cardiovascular risk assessment, and prevention and long-term surveillance. Treatment of cardiovascular conditions in cancer patients generally follows the AHA-ACC guidelines with some individualized minor nuances.